Welcome to the Green Surgery Conference 2021. My name is Dr. Olivia Bush. I'm the Clinical Programme Director at the Centre for Sustainable Healthcare, and we are co-hosting this event with the Royal College of Surgeons, and I'm delighted to have Neil Mortensen here, the President of the Royal College of Surgeons England, with us. Thank you. So today we're inviting you here to imagine surgical care being transformed to become more environmentally as well as socially and financially more sustainable. And to do that, we're going to help you to showcase 5 surgical teams from the UK who have risen to the challenge of making green surgery happen where they are. The Green Surgery Challenge is in fact a programme which was launched on the 3rd of February this year, and teams competed to receive mentoring from sustainable healthcare specialists in our team. And over a 10-week period, they honed a specific question, designed a project, implemented a project, and measured the outcomes. And they used a sustainable quality improvement approach, which is a specific methodology for integrating sustainability into quality improvement methodology. And this challenge has been carried out, has been run by our team, and with the strong support of a range of partners and sponsors. Next slide, please. And you can see all our fantastic supporters here. In particular, I'd like to mention our gold funders and sponsors, NIHR Surgical MedTech Cooperative and Elemental Healthcare, and also our silver partners and sponsors, the Royal College of Surgeons England and the Royal College of Surgeons Edinburgh. So just to outline the programme and what will happen today. So we'll have I'll introduce you to some of the key concepts, and the presidents of the Royal College of Surgeons in Edinburgh will put this into context from their perspective. We'll then hear about the projects that have been carried out. And after a brief break, where there'll be the opportunity to network, we're asking for you to join workshops and help find solutions for spreading and scaling some of these green surgery initiatives. And then we'll come back together towards the end to hear who has won the prize, the cash prize that is up for grabs for their project. And then we'll end with just some information on some resources that are available for surgical teams who want to carry out similar initiatives in their context. So what I'm going to do now is to give you a little bit of a background, next slide please, on the environmental impact of surgery. So just some facts for you. So the pie chart represents the total carbon footprint of the NHS. I suppose really we're thinking, obviously climate change really impacts on health. But what we are doing as well as a health system is undermining health of the population by contributing to climate change itself. And the NHS has a carbon footprint of, which is 4% of the total carbon footprint of the UK, which is enormous for one organisation. And that's equivalent to the total emissions of Croatia. There is an agenda set by the NHS to aim for net zero by 2040, which was set out in the net zero strategy for the NHS back in October last year, which makes us a really pivotal moment alongside. Of course, at the moment we're in the midst of COP26. So to just put this in context about why this is important for the surgical community. So operating theatres are the most resource-intensive area of the hospital. So they contribute up to 30% of the total waste output of the hospital, and theatres have 3 to 6 times higher energy consumption than other areas of the hospital. And if we think about a typical operation, that is 150 to 170 kilograms of carbon dioxide equivalent per operation, which is similar to a trip from London to Edinburgh in a petrol car. If we're sort of thinking about moving to solutions here, hotspots for tackling these problems are energy use, anaesthetic gases, and consumable equipment. And you'll see some of these themes, hotspots tackled in the case studies that you'll be hearing about later. So this is a quote from the net zero report that I mentioned earlier. So as I mentioned, it says, our intention is to construct the most ambitious, credible declaration to reach net zero of any national healthcare system in the world. However, this can only be achieved if they are supported by collective action from all NH staff and collaborative relationships and partnerships within and beyond the NHS, as well as appropriate investment. So really, this is why the Green Surgery Challenge came about, as a way to upskill members of the surgical community to be leaders, to have the right skills to make these changes. So obviously, this is I'm going to call on now. Obviously, we have COP26 we're in the midst of that at the moment, and at this moment, I'd like to call on Professor Neil Mortensen, President of the Royal College of Surgeons England, to set this agenda in context and let us know what the Royal College of Surgeons England are doing to tackle this area. Thank you, Neil.
And thank you, Olivia, very much. And hello there, everybody. This is very exciting. I'm absolutely delighted to be here, actually in our new greener college building, just recently reopened and refurbished at the time of COP26. And we're going to try and show how we in surgery are making a contribution to the overall sustainability agenda. As you've heard from Olivia already, the operating room with all its packaging, disposables and gases has the biggest carbon footprint in our hospitals, so we have to do something about it. It's our core responsibility of both this college and the colleges more generally to help make surgery greener. And we must look at how we can help drive wider adoption of more environmentally sustainable surgical techniques across the NHS. So our Sustainability in Surgery Group was established in 2019, and we have members from our council, the dental faculty, trainees, and others with experience and a special interest in the area. We plan over the coming years that with research, education, and lobbying, we'll change attitudes and behavior in the OR and in hospitals and the NHS more widely. Most important of all, this is an intercollegiate endeavor. This is an area where we have to collaborate. So sustainability is a key element of our strategic aims, and I'm absolutely delighted that we are co-hosting the Green Surgery Conference with the Centre for Sustainable Healthcare. And as you'll find out, surgical teams from across the UK will be presenting their innovative approaches to reducing the carbon footprint of surgery. And we are all absolutely dying to hear how they've done. Thank you.
Thank you so much, Neil. Next slide, please. So I think that underlines really that green surgery is the future of surgical practice. Thank you. So as we move towards introducing the teams and their projects, I'd just like to introduce you to two helpful concepts. That's right. So the first is the principles of sustainable surgical practice. So we've got, you can see there's a pyramid here with the most, and there are essentially four different principles that we can use to look for solutions. And the first of those is at the bottom, and it's at the bottom with the biggest chunk of the triangle, because that is the most effective element, which is essentially preventing surgical disease in the first place, whether that's primary, secondary or tertiary prevention, which is something that isn't quite so much thought about often, I think. The second principle moving up is the second most powerful, which is patient education and empowerment. So shared decision making and making sure that the intervention is going to achieve what is something which is valuable for the patient is actually pivotal in this area. And making sure that we include patients in service design and so on. And then the third element is lean service delivery. So making sure that every step counts and we've got efficient care pathways. And then the last section, which is I think where we normally focus, which is good, but it's just useful to notice this is one of the least effective areas, is around low carbon options, so reusables and recycling, repair and maintenance of instruments. So these principles give you an idea about what solutions to look for. And then when we're looking at how to measure outcomes, we're basically looking for sustainable value. And so how do we define this? It can be looked at as an equation or this Venn diagram. So essentially what we're looking for is good outcomes for patients and populations with the minimal costs that are allowed to make it efficient. So we often think of financial costs and impacts, but here we're proposing using the triple bottom line of costs, which is looking at environmental and social impacts as well. So when we're looking to move to the Venn diagram, when we're looking for sustainable healthcare, we're looking for that sweet spot where healthcare delivery is good for people, it's good for the planet, and it's good for the public purse. So the question is, what does this look like in practice? And that's where we move to discussing these fantastic case studies and projects that have been carried out literally over 10 weeks by our 5 finalists of the Green Surgery Challenge. Before we hear from the teams, though, I'm going to hand over to my colleague Frances Mortimer, who will introduce the judging panel. And what will happen now? The teams will each present their give a presentation on their projects for 5 minutes, and then they'll be followed by 5 minutes of question and answers from the judges, who will then go and deliberate later about who they think should take the winning prize for their efforts. Thank you very much, Frances. I'd like to introduce my colleague, Frances Mortimer, who is the Medical Director at the Centre for Sustainable Healthcare, one of the founding members of the organisation, and who also devised the principles of sustainable clinical practice and the concept of sustainable quality improvement. It's wonderful to have you here, Frances. I'll hand over to you now. Thank you.
Thanks very much, Olivia. Yeah, it's my pleasure to introduce the judges for today, who represent a breadth of deep experience and expertise in surgery and quality improvement. First of all, I'd like to mention Tim Goodacre, who's the Vice President of the Royal College of Surgeons in England, and also a surgeon working clinically in Oxford, specialising in the management of cleft lip and palate. Alongside clinical interests, Tim is an enthusiastic teacher, both within the medical school, and has been regional specialty advisor for postgraduate training. And lastly, chair of professional standards for the specialty. So wonderful to have Tim and the partnership of the Royal College of Surgeons in England throughout this whole challenge. Secondly, Mrs. Scarlett McNally. Scarlett is a consultant orthopaedic surgeon at Eastbourne with an interest in hand surgery and trauma. And as well as her clinical commitment, she leads on increasing day surgery rates, streamlining the patient journey, and increasing the skills of the multidisciplinary team. And Scarlett is also Director of Medical Education in Eastbourne, as well as being the Deputy Director for the Centre of Perioperative Care and former member of the Council of the Royal College of Surgeons in England.
Just to continue, so Mr. Eniola Folarami is the training programme director of paediatric surgery in Wales, and so represents the future generations really through his work in paediatrics, and also an important element in education as well. And then finally we have Dr. Kedar Mate, who is representing I think Francis is back, our quality improvement element, because he's the president of the Institute of Healthcare Improvement, the global leader in healthcare improvement. In fact, so we're honoured to have him here with us. Welcome back, Francis.
I'm sorry, I had a feedback.
Don't worry, that's okay. It's we're all getting used to the technology. I've just finished introducing Eniola Folarami and Kedar Mate. And so it's the first team is Derriford. We've got Pete Labib, who is a senior surgical registrar, and Bryony Ford, who is an F2 doctor, who have both done a fantastic project and with a real strength of engaging their teams, the surgical department in Plymouth. Wonderful. So Bryony has joined, and so has Pete. Wonderful to have you here. Pete and Bryony, we're just waiting for our judges to come in. I think we'll have Eniola arriving shortly.
Hello, my name is Bryony and this is Pete, and we're going to be talking to you about our project on reducing single-use surgical instruments in laparoscopic appendectomies. So our team comprised of Pete and myself, 3 consultants, each representing a different general surgical specialty, and Shelley, a clinical procurement specialist. So we're going to present this as a how-to guide, so others can use it as a starting point for implementing similar change. So get your colleagues involved early, including non-surgical staff. Having Shelley, our clinical procurement specialist, involved was essential to the success of our project. Also, clearly define the problem you want to solve. So we noticed in our trust that colleagues were generally dissatisfied with the appendectomy set and reported having to open single-use instruments frequently. Reasons given for this included instruments not being on the set or not working well. Colleagues also had safety concerns about the sharpness of existing trocars and therefore often requested the disposable option. Then we introduced the concept and importance of sustainable surgery to our colleagues and sent out surveys on their response to this and their perceived use of single-use items in appendectomies. As expected from discussions, only half of our colleagues were satisfied with the existing set, and there was a high self-reported single-use instrument consumption, especially Johans and ports. Whilst colleagues' opinions were helpful, we needed hard data on what was actually being used. So we audited 25 consecutive appendectomies, collecting data on single-use items. In these 25 cases, 109 single-use items were opened, with 12mm ports and Johans opened in every single case. All items opened have a reusable alternative that could be included in the set.
Now that we understood what our current practice was like, we wanted to estimate the financial implications of this as it currently stands. We currently do about 500 appendectomies in our trust every year. If the 25 appendectomies were representative of our normal practice, this would translate to over 2,000 single-use surgical instruments and ports that were being used every year, which could otherwise be reusable alternatives within the set. This costs just under £50,000 per year. Of course, it's not just the financial implications, but also the environmental costs associated with this practice. Turns out that our instruments aren't made locally. Apart from one of the ports being made in the Netherlands, the other ones were coming from California, Taiwan, and China. And when we carbon costed these instruments, it turns out that there was an associated 700 kilos of CO2 equivalent emissions to do with the production, transport, and destruction of these items. So now that we understand what the problem is, we wanted to propose a solution. We found a new type of reusable port and contacted a medical device company who gave us some trial ports to try out. We gave them to our colleagues who were very satisfied with them, and it alleviated their concerns about the existing reusable trocars. In addition, we've also priced in for including additional and replacement reusable instruments for the set to prevent the need for people to feel that they have to open single-use items to complete the procedure. The cost of buying these additional items is less than £20,000, and the ports are expected to last around 7 years based on how often we use them at our hospital. Presuming that the revised appendectomy set will reduce our instrument usage by 75%, which is a conservative estimate, this is likely to prevent the need for more than 11,000 single-use surgical instruments and ports, associated with a financial saving of £240,000 and 3.6 tonnes of CO2 equivalent emissions. In other words, we have changed our set to have safer design reusable ports and trocars to reduce our patient risk. This will be associated with annual savings of £34,000, and the new instruments will pay for themselves within 6 months of purchase. This is associated with saving over half a tonne of CO2 equivalent emissions every year. From a social perspective, the surgeons are happier with the new appendectomy set. This project has also spawned a number of splinter projects. Colleagues are now interested in looking at making changes to the cholecystectomy set. Two of the team members are now also members of the Trust Sustainability Committee. And there's also been a wider conversation about energy efficiency in theatres, with a plan to try and switch off the air conditioning and heating units in theatres overnight, which will have a significant impact on our emissions. Our top tips for your own projects: try and take your colleagues with you. It's quite easy as well to demonstrate that environmental savings can also translate to financial savings, especially when moving from single-use to reusable instruments. This will make it easier for you to get approval from your finance department for small amounts of capital investment to make your changes. And most importantly, befriend other departments. This project wouldn't have been possible without the collaboration with the Sterilization and Decontamination Unit and Clinical Procurement. And the wider discussions we're now having about the air conditioning units in theatre involve teams such as estates and infection control. With that in mind, we would like to thank all of those teams and also our theatre staff, especially Nympha, Steph, Nikki and Paula, who were instrumental in getting the audit off the ground, and everyone else involved in the project. Many thanks for your time.
Excellent. Thank you very much, Pete and Bryony, for that fantastic presentation. And it was really good having the top tips at the end, I think, as well. Thank you. Right, so I'm going to hand over to our judges now to ask a question. I think, Francis, you're the nominated judge to ask a question of this team. Thank you.
Thank you. Thank you very much. What a fantastic project. And I really like the way that you'd, set out and decided to target the area of consumables within surgery as end users. I just wondered if you could tell us a little bit more about the working across departments and what you'd learned from that and what you'd done that you perhaps hadn't done before in that area.
Bryony first.
I was going to say initially when we started, we actually spoke to a wider cohort than just the general surgical team, because laparoscopic procedures obviously aren't just a general surgical thing. So we actually engaged a much wider cohort of surgical staff first. And then when we were looking at exactly what we were going to refine down for our exact project, we realised we needed to focus a bit more specifically on one kit to be able to do all of these financial workings and look at making it sort of a reasonable project to do within the 10-week timeframe. So that was actually really useful then at the end to come back and be able to feed back to these other colleagues who had initially got involved and show them what we'd done. And obviously, because we'd engaged them right at the start and sort of got their interest in their laparoscopic procedures, we then could come back to them at the end and say, this is what we've done and this is how much we've saved and this is what we're going to be doing. So I think that really helped for gauging interest at the end.
Fantastic. And how, what steps have you taken to embed the change for the future? Do you think it's going to be sustained?
So the benefits of getting SDU involved is that once you make those set changes, those are permanently embedded like that. So as the staff change, that set will survive. Us as junior colleagues working there. Some of the team, well, 3 or 4 of the team members are permanent members of staff who now have interests, well, higher interests than before the start of the project in sustainable surgery. And it's really nice actually being approached at the end of we presented our results to our department. And the amount of colleagues that contacted after saying, oh, we also want to do these things. But yeah, I think embedding it's not just a behavioral change, but actually the systemic change of permanent changes to sets is something that will last. I must say a special thank you actually to estates as well, who were a hidden gem for information for this. So trying to estimate carbon emissions from our theatres so we could put into context what our results mean. Which included things like estimates of energy usage per meter squared in theatre and so on. So that's given colleagues a sense of scale, because it's easy to say, oh, we're saving half a ton of carbon a year, but without knowing what that means in context of our theatre consumption. So I'd say estates were really integral to us being able to put our results into context for our colleagues.
Thank you very much.
We're out of time actually, but we'll move on to the next team. Thank you very much, Pete and Bryony. It was really enjoyed working with you. We'll look forward to hearing a bit more from you later. Fantastic. Great, thank you. And 2 of our judges have arrived as well. Welcome, Eniola Folarami. It's great to see you from Wales. And Dr. Kadar Mate, thank you very much for joining us as well from the US. We've got an international audience here. Fantastic. Thank you. So our next team is the Leeds team, and we have Adam Peckham-Cooper and Aaron Quinn presenting today. Good to see you both. Welcome. Adam is a consultant emergency general surgeon and honorary senior lecturer at Leeds. And Aaron Quinn is consultant general surgeon and associate clinical professor of surgery and the deputy director of NIHR Surgical MedTech Cooperative as well. Wonderful to have you here with us. Look forward to seeing to hearing about your project. Thank you very much.
I'll unmute myself. That's normally a good start. Sorry. Good afternoon, everyone. I was saying thank you, Olivia, and thank you for allowing us to present the Leeds entry today. As I said, my name's Adam Peckham-Cooper. I'm a consultant emergency surgeon, and my co-lead for this project, Mr. Aaron Quinn, is a colorectal surgeon also at Leeds, and he's going to present the second half of this presentation. Next slide, please, Olivia. Jane, sorry. Leeds is a busy acute trust with strong ties with global surgery and innovation. The Green Surgery project, as such, dovetailed really nicely with work being undertaken to develop a gasless laparoscopy technique. However, it was important, we felt as a team, that we all look at the whole process, not just in a single element of that particular procedure from start to finish, and identify areas throughout that we could target and improve. And so we picked, again, the laparoscopic appendicectomy. Next slide. Starting with a full process map of the existing pathway, we were able to identify a number of areas whereby where we could introduce novel and sustainable improvements to the existing techniques. Next slide, please. Allow me to take you on a tour. This is a standard green appendicectomy set up as in Leeds that we do in Leeds. You can see we use disposable drapes, single-use ports, disposable hats and gowns, a catheter normally as standard, and remarkably 119 items on a tray, including plastic gallipots and plastic kidney dishes. Some key areas of waste, I think you'll agree. This is a green appendicectomy. Gasless laparoscopy using the raised device, reusable drapes, gowns and hats, no catheter, we ask the patients to have a wee, and a reduced green tray, one tray, 41 items, all reusable and non-disposable. Next slide, please, Jane. So what is the impact? Our green theatre checklist now includes asking the patient to have a wee in theatre to ensure the bladder is empty. Removing a catheter saves 0.83 kilograms of carbon per procedure and 306 kilograms of CO2 in the trust for a single procedure based on an 80% applicability rate. Next slide. The green laparoscopic tray saves 1.77 kilograms of carbon per case and 745 kilograms of carbon annually if we use that for the majority of our 522 cases per year. There's also a good financial driver additionally, with a saving on almost £10,000 a year. Next slide. Over the last 10 years, the Trust has moved away from using reusable drapes, gowns and hats, but washing them and not throwing them provides significant environmental benefits, with a carbon saving of 3.84 kilograms per procedure. That translates to a staggering 152,000 kilograms of carbon nationally across the 41,600 appendicectomies done annually if we could implement that nationally. Next slide, and I'll hand over to Mr. Quinn.
So in addition to those changes that we made, we also used the retractor for abdominal insufflationless surgery, the raised device. And this was developed really out of a desire to improve surgical care in rural India. The uptake of laparoscopic surgery in these areas was limited by access to general anesthesia, carbon dioxide, and the cost of expensive laparoscopic instruments. The raised device was developed as part of the Leeds NIHR Global Health Research Group, and the training required and the device has been distributed across Northeast India, leading to widespread policy uptake at regional and national level. Next slide, please. Whilst the raised device was born out of necessity in rural India, it could provide safe and sustainable solution for common laparoscopic procedures in high-income countries as well. The previous slide, that was the final prototype of the device. It's manufactured in India and compliant with all required standards. This is an intraoperative picture of the device in use for cholecystectomy, and to date, it's been used safely in over 200 procedures. Next slide, please. So looking at the impact of the RAISE device in our pathway on carbon and the financial savings, breaking it down as per the other interventions, you can see per procedure saving of 410 kilograms of carbon. And as you can see, the impact of the insufflator gas on overall emissions dwarfs all the other environmental considerations within the scope of this project. Now, as earlier demonstrated, we conducted 2 cadaveric appendectomies, recreating environments and instrument use as close to real life as possible. And one of the most striking and memorable moments of that day was the realization amongst the team of what could be achieved, particularly in waste reduction. This is a photograph of the volume of waste from a standard laparoscopic appendectomy. And this is compared to the waste of that of a green appendectomy. Breaking it down, you can see the dramatic reduction, not just in packaging waste, but clinical waste too. Next slide, please. And when you look at our overall waste, similar operating times, but as Adam's already said, we reduced the number of instruments from 119 down to 49. We completely exclude the use for insufflator gas, and the clinical and packaging waste is dramatically reduced. So the bottom line is that this is a realistic and sustainable alternative with significant carbon and financial savings. And this is just looking at the impact locally and nationally on changing appendectomy pathways. The green appendectomy also lends itself to other commonly performed laparoscopic procedures such as cholecystectomy and hysterectomy. So in summary, this has been previous slide, but in summary, this has been an amazing project. Adam and I worked with a talented team full of enthusiasm. And the green appendectomy provides a solution for a common surgical problem that is both equal in efficacy and safety compared to standard. There are significant financial and carbon savings, and looking beyond the project and the ambitions of the global surgery team, the impact could be immense. Thank you.
Fantastic. So I'll now move to the judges. Scarlett, I wonder whether you could ask a question, please, of the team. We're going to keep it fairly short, with us just a couple of minutes to go before the next team.
Thank you very much, and well done on basically a number of projects within there. In terms of the reusable items, drapes, and so forth, people in the UK often come up against infection control and also the cost of re-sterilisation. Did you find those to be particular barriers? Are there suggestions you can make to other organisations about those issues? Thank you.
Aaron, shall I turn that? So we haven't found widespread barriers from infection control, I have to say. We have been quite careful in implementation, in as much as we haven't deliberately done it in a wholesale fashion. For some of those reasons, we have now what we call a green checklist. So when the laparoscopic appendectomy is kind of sent for in the theatre brief, at the bottom of that there is a do you wish to do this green type box, and that then implements the next stage of the green pathway in terms of reusable drapes. We have a separate external contract with B. Braun from a sterilisation perspective, and there are already existing reusable drapes within the trust as a standard anyway. They're just not widely used, but I certainly haven't experienced any particular backlash from that perspective. I guess from a tips point of view, it's probably a slow implementation. I think, as with anything in the NHS, as I'm sure this panel is well aware, if you go in kind of all guns blazing, it doesn't necessarily work. So we're drip feeding still, in truth.
Great, thank you very much indeed for answering that question, and thank you very much for your entry. It was very, very inspiring, useful to have that element of innovation. Fantastic. So we'll move to the next team now. which is the team from Sussex.
Hi everyone, my name's Alice Robinson. I'm a core surgical trainee in Brighton, and I'm here with Professor Mansour Khan as well. And we believe that sustainable surgery should really start before the patient even enters the operating theatre. So something we explored was whether we could actually eliminate the second group and save for laparoscopic cholecystectomies. So in an idealistic world, when everything's really simple, this is the very basic pathway that a patient will end up having a laparoscopic cholecystectomy. So when there's a clinical need, they'll then attend some sort of preoperative assessment. They'll need to get some preoperative investigations done. And at our hospital, that includes a full blood count, a urea electrolyte, liver function tests, and a first group and save. Those are the kind of basic bloods that are taken, usually at the same time as pre-op assessment. They then need to come back again to have a second group and save done. And it's usually the case in most hospitals that this needs to be within sort of 5 or 7 days before the operation for it to be a valid sample. The reason that we need this test is that if anything goes really untoward or goes really wrong in the operation, causing lots of bleeding, that the blood can be cross-matched quickly and taken to theatre for the patient to use. But bringing patients back for this second test is somewhat problematic where we live and where we work, because we cover quite a large region, and the majority of preoperative assessment is done where that red star is, at the Princess Royal Hospital in Haywards Heath. And that's 15 miles each way from Brighton, which is where the orange star is at the bottom, where most of the population is kind of more densely populated. And ultimately, a laparoscopic cholecystectomy is quite a safe procedure. Many, up to 70,000 are done each year in the UK, and the overall bleeding and hemorrhage risk is really low. So we wanted to show that in terms of maintaining outcomes for patients. So could it be safe to eliminate that second group and save? So as part of a literature review, we looked at 17 studies internationally, which included just under 500,000 cholecystectomies. And overall, the transfusion rate was 0.36%, so very low. And this didn't really specify whether that was intraoperative or postoperative transfusion. But when we repeated this in our own, as an audit in our own hospital, of 243 lap choles, only 2 patients ever required a transfusion. Neither of them were intraoperative, and they both occurred after the operation. And at that point, the patients then had to have another group and save anyway. So we think it probably is safe to get rid of that second group and save blood test. And what impact would that have? Well, we obviously carbon footprinted some of these preoperative blood tests in the context of having them done as an outpatient. So the first set of tests that I mentioned amount to about 12 kilos of CO2 equivalents per set of tests. And coming back for that second group and save is another 10 kilograms of CO2 equivalents. And if you look at how that's broken down, that's because, as I mentioned earlier, patients have to travel quite a long way to get that test done. And I'm sure it's the same in a lot of trusts where other people work. Patients need to travel to get that blood test done. And what that really equates to is that second group and save test, which we think is probably safe to eliminate, is the equivalent of a 225 gram beef steak, or over a year at our trust, 7,000 journeys between COP26 and the G7 climate in Cornwall. And overall, I mean, we've alluded to how much single-use equipment is used in our hospitals, particularly in surgery, and all of these pieces that we need to do blood tests on patients, we use a lot of, as you can imagine. So at our trust, we use over 2 million blood bottles a year. So we should really start to think about how many of these tests really are necessary, because that's all single-use stuff that's going to go straight in the bin. In terms of the patient impact, we surveyed some day case patients and found that almost all of them travelled by car to attend appointments and blood tests, spending between £5 and £10 a trip. And the survey that we did was predominantly on an older group of patients, but of those of working age, they all needed to take time off work to attend these appointments, which seems like quite a big impact on them if it's not really necessary. And another important social aspect is thinking about the supply chain. So it might not have affected your hospitals, but certainly where we were back in August and September, we had a huge problem with the blood bottle supply chain. So instead of being reactive to these issues and cutting back on unnecessary testing, we should really be proactive and perhaps rationalise what we're requesting at all times. And of course, there's a financial impact. Blood tests are a lot more expensive than you might think, and a group and save can be anywhere between £12 and £20, depending on the trust. So even as a conservative estimate, with 250 lap colis on average at our trust, with £12 per group and save, that's £3,000 a year on a test that we don't really use. So overall, if you can take away just one blood test for just one operation type and show that it can be safe for patients, you could save up to £5,000 a year, 2.5 kilograms of CO2 equivalents. And of course, those patients don't have to take that time off work and travel, and our hospital services can have a slightly alleviated burden. So it's a very simple idea, and I really do encourage you all to think, can you reduce perioperative testing in your own specialty? Thank you.
Thank you very much, Alice, and for ending with such a thought-provoking prompt. That's really wonderful. Now, I was wondering whether you could please ask Alice a question. Thank you.
Sure. Yes. Thank you so much. That's a wonderful presentation, and it's great to see how you've used so many of the quality improvement tools to map the process, the patient journey, as it were, and that's been a big factor in how you think about this. I actually have two questions for you. The first is about what barriers you think you'll have to actually implementing this. You've modeled this out very well, demonstrated the potential savings both in cost as well as in carbon impact. What's the challenge to putting this into practice at this point? Seems like a very logical recommendation. And my second question is, you showed on that map, kind of where the sampling is done versus where the population center is. As you consider expanding to other potential surgical areas, is there any possibility of moving the place to sample to be closer to people in the future, so that actually you save not only on group and save number two, but also by eliminating it, but also on the first perioperative sampling strategy? So two different questions. Thank you.
Yeah, thanks. They're both really good questions. In terms of the response to the first question, how difficult and what barriers were there about getting it into practice? Well, of course, surgeons are one side, and the anaesthetists, you need to get on board with these sorts of changes, because ultimately they are responsible for preoperative planning and preoperative assessment. And that did prove to be quite difficult, because historically people like to have the group and save available for laparoscopic procedures. So I presented the work at our anaesthetic governance meeting. It did get a favourable kind of interest from the anaesthetists, and it's hopefully going through the governance process at the moment to get that formally changed. So I think it's about engagement and ensuring that you've got everyone on side, and certainly the head of preoperative assessment is always looking for ways to sort of cut back on some of these tests, because they recognise that a lot of what we test for probably isn't needed. It's just default status quo. It's been there. That's how we've always done it. So it's kind of challenging those processes that's really important. And coming on to your second question, certainly, yes, over a big area, the ideal situation would certainly be to allow patients just to attend their nearest hospital for a preoperative assessment, for preoperative tests. And ideally, it should be a one-stop shop at their nearest trust to really cut back on that travel. And I think that's definitely the way that we should be going. But it can be, I suppose it's quite a big institutional change, because at the moment all patients go up to that other site for not just the blood tests, but for BMI, blood pressure, anaesthetic assessment, etc. So at the moment that's where it's all done from an efficiency point of view. But certainly I think that does need to be considered. And actually at our trust we are going to be bringing in an electronic preoperative assessment system. So thinking about what tests are needed and when will be really integral to that process, because perhaps there'll be some patients that don't need that contact with the hospital at all.
Wonderful. Thank you very much, Alice, for your full answers to those questions, and thank you, Professor Khan, for joining us as well. I know that you worked together with Alice on this project. Wonderful. So that concludes this team's entry and presentation. So we'll move to the next team now. So this is team 4, and I'd very much like to welcome our team from Wales, Mr. Prash J. Sudasan and Mr. Pritam Kudimuri, who are both consultant to hand and orthopaedic surgeons who put together a team in their trusts. Fantastic. So I think, Prash, you can start, and we'll look forward to Preetam joining us shortly. Thank you.
Okay, I shall get started. Hi. Hello, everyone. My name is Prash Jaysadas. I'm a consultant hand and orthopaedic surgeon in Bangor in North Wales, Betsy Cadwallader Health Board. And myself and my wingman, who is AWOL at the moment, Mr. Kudamuri, another consultant hand and orthopaedic surgeon in Wrexham. Together, we did this project with our team in North Wales, looking at the upper hand of sustainability, basically looking at whether we can make a carpal tunnel decompression much more sustainable. Next slide, please. So we can go over this one. Carpal tunnel surgery is the most common orthopaedic procedure with 53,000 operations done per year. And as we've already mentioned, a large amount of hospital waste is generated via the theatres. Next slide, please. So our aims were to develop a lean green instrument setup, identify much smaller drapes, set a patient on a green patient pathway, and try and utilise a minor procedure room. Next slide, please. So this is Mr. Kodamuri's green set on the left-hand side, and this is his standard carpal tunnel set, which we was using previously. And you can see immediately the big difference. Next slide, please. The traditional drapes are procured centrally, so we get an extremity pack with a vast amount of drapes and single-use plastics that we really don't need for a minor hand operation. So these are the traditional drapes used in a carpal tunnel decompression. And you can see there's a lot of plastic in there as well. Next slide, please. So the disposables, as you can see, this is all from one 10 to 15 minute procedure. So there's quite a lot of disposables that we really need to try and do without. Next slide, please. Sorry, go back one. So the other interesting thing we identified is we only have a certain number of carpal tunnel sets in our hospital. So when we run out of carpal tunnel sets, bearing in mind we can do 10 to 15 of these in a list, we open a standard orthopaedic handset, which you can see on the left-hand side, which has all sorts of stuff on that we don't need. And this is compared to the green setup on the left, on the right again for comparison. Next slide, please. And this is going back to the drapes. So this is the traditional draping set, which we use for any extremity surgery, even sort of joint replacement surgery and things. Huge amount of drapes that we don't need. And our two 90 by 90 drapes for a minor hand operation, which you can see there on the right. Next slide, please. So sorry, this slide's not coming up appropriately. But what we tried to do, the first stage of the process was to sort out the drapes and the instruments, and the second stage was, can we bypass a ward admission and do the surgery in a minor procedure room? So rather than coming onto a large major ward, we use a smaller facility. Sorry, this slide's not projecting well. Can we move on? Thanks. Next slide. So obviously, to the backdrop of the pandemic, we were only able to perform 4 lean green hand surgery lists with a total of 17 patients across the 2 sites. We had no issues, no infections. We had excellent patient experience feedback. And interestingly, we had some patients who came back for bilateral surgery, had one side done the old way and one side the new way. And the experience was overwhelmingly positive. And it was hugely positive from the staff as well, from the theatre staff. So looking at the standard list, this is how much waste we generated from a 10-minute procedure. So there's almost 3.5 kilos of waste, most of which is plastic, all of which is incinerated. And on a green list, we drop this down to 1.2 kilos on average. So looking at the carbon savings, this totaled at 31 kilos of savings per case. Now, breaking this down, half of this is due to the smaller instruments and smaller trays. The smaller drapes and bypassing the ward adds a small amount of savings as well. Further indirect savings are due to water usage and moving out of a laminar flow orthopedic theatre to do this in a smaller procedure room.
The only thing I would carry on and say is that this journey has been a brilliant journey for us. We've involved quite a lot of people, like other teams have described in the previous presentations, procurement, theatre team, even the patients on board. What we found was that with small changes of decreasing the instruments and drapes, we could reduce the clinical waste generated completely by 2/3, and also reduce the carbon footprint by almost 80%. And also attractively, financially for the financial department, cut down the savings or cut down the cost by about 2/3. But universally, all across the board, all the patients had excellent outcomes. And I, in fact, had a patient yesterday who came through this pathway and was asking for the same again. So annual cost savings projectionally for such a commonly performed small procedure as a carpal tunnel, we on a conservatory estimate, if we thought that we could do about 3/4 of these on green pathways, the savings for the trust were about £12,500, but these annual savings in terms of carbon emissions were close to 12 tons. But the more important thing for the patient's journey was that it bypasses the ward admissions, it increases the productivity, and it is a safe procedure with reproducible steps. But more importantly, these principles that we learn could be scalable to bigger surgical procedures like elective hip replacements, knee replacements, where you'd see a lot of trays that are utilized, and a lot of waste generated. I mean, the more important thing for us was smaller setup made such huge changes. But we want to push forward and say we want to design greener patient pathways where we want to decrease the patient's contact or the amount of times they come into the hospital. And that's actually, this project has actually helped us as a catalyst to look at what we can actually improve in terms of the whole of the patient's journey through the hospital.
Fantastic. Thank you very much indeed, Prash and Preetam. It's really wonderful to hear what you've achieved. So I'd like to call on Mr. Folarami, please, to ask a question of the team. Thank you.
Thanks, Olivia. Yes, just like to commend you both on your excellent work. I think looking at your figures, 65% reduction in waste, 80% reduction in carbon footprint, that's pretty impressive. Just a few questions, because I'm cognizant of the fact that many of your colleagues are very keen on maintaining patient safety and infection control, especially in orthopedics. I noticed one of the pictures you put up of the drapes, you use significantly less drapes, and I saw a good proportion of the patient undraped. Have you noticed any increased risk of post-operative infection? Have you had any misgivings by your colleagues? And lastly, what's been the uptake of this amongst your other colleagues performing carpal tunnel in terms of percentage uptake?
So far, only myself and Preetam have done the green pathway, but overwhelmingly, our consultant colleagues are extremely interested in this. So I think the uptake there's a huge amount of enthusiasm. 2 or 3 of my colleagues came into my last green list to watch how I'm doing it. And it's also training the juniors as well. The registrars are hugely keen on doing this. And the other thing we're doing as well is not using the classic sponges to clean the hand. So we're actually just using chlorhexidine spray to actually spray the hand. So we're not using throwaway sponges and more instruments. Yeah, overwhelmingly positive. People can't wait to get stuck into this.
Wonderful. Thank you very much. Were you about to say something, Eniola?
No, just the first part of the question. Yeah, please, Preetam.
The infection rate, yeah. So the last patient on this list was at the end of July, and we followed them up to 3 months just to make sure that that wasn't the case. And of the 17 patients, none had any infection. And since July, I've done a few more lists with the same pathway, and touch wood, until now, I've not had a single case of infection.
Yeah. Also, Eniola, you don't need to drape the whole body. You don't need to drape the whole body for a minor hand operation. You know, the surgical field is very small. So why do we need to cover the whole body of the patient? It's just not necessary. And there's plenty of data from around the country, around the world, There's a colleague in Canada, professor of hand surgery, who's done over 1,000 of these in his office without any incidence of infection. So we're late to the party here. This is the way it should be done.
Excellent. Thank you.
Wonderful. Thank you very much for your questions, Mr. Folarami, and for Prash and Freeton for your fantastic presentation and your achievements. Really exciting to hear about. Wonderful. So we're on now to the final team of our projects, and I'd like to introduce the team from Imperial College. And I'll just introduce them briefly. So we have 2 surgical registrars and clinical fellows, Jasmine Winterbeatty and also Jonathan Gann. And I think Jasmine's leading on the I know Jasmine's leading on the presentations today.
Okay, super. Thank you very much for having me. My name is Jasmine. I will be presenting the results of the Imperial Green Surgery team and our efforts to go green. As for the other teams, our efforts were really aimed at reducing the carbon footprint of our department whilst achieving the triple bottom line of sustainability and, of course, maintaining, if not improving, the clinical outcomes for our patients. So we went back to our departments, we tried to study the problem and spoke to lots of people, did some process mapping and tried to identify carbon hotspots within surgery. And what we really were determined to do as a team was to try and identify these interventions that could be immediately implementable and that would have longevity as well. And in order to do so, we thought that it would be best to use what resources we had already in the hospital, both in terms of the know-how, the expertise, and the technical equipment necessary. And we thought that this familiarity would really help us gain the support of the stakeholders involved that, as you know, can be averse to change. We also thought that the principles of marginal gains would be really applicable to trying to improve the carbon footprint of what is already a very well-oiled and highly performing team, so the surgical team. Obviously, there were lots of interventions that we could have done, and we started by the 2 that I will talk to you about. The first was to try and eliminate the carbon footprint of general anesthesia, which is related both to the volatile anesthetic gases that are very potent greenhouse gases, as well as the associated increased pathway for patients. And the second was to try and combat the huge carbon footprint of consumables. And we know that single-use and disposable items are particularly problematic in this area. So we reintroduced reusable gowns. And both of these, as you've probably gathered, are of course extremely familiar to most of the staff in operating theatres. Everyone has worked in a department with reusable gowns and done hernias under loco at some point. And of course, the last thing we wanted to do, but also very importantly, was to try and get sustainability on the agenda. So looking at inguinal hernias, we knew that there was a wealth of evidence already in the scientific literature that suggested that there are a lot of clinical benefits for patients undergoing this procedure under local or regional, with or without sedation. We also knew that there are some benefits and mitigation of COVID-19 associated risks for both patients and staff. So we looked at our data from our trust, and we found that in 2019 we performed only 3.4% of our cases under local, although interestingly, if we included private numbers, that went up to 28%. We looked through the literature, we found reports of trusts doing up to 64% of their caseload under local, and therefore we thought that should really be the numbers that we were aiming for as well. The other interesting thing that came out of our 2019 data is that we had an unplanned overnight stay of 11% in the GA group, so 1 in 10 patients, as opposed to the less than 3% for the local anesthesia group. So we pulled together the criteria for local anesthesia, and we shared this with the whole consulting body to gain a consensus. Having done that, we identified patients that had been booked, and we called them up to offer them, or did so on the day, depending on the case. But mostly we called them up and offered them the option to have the procedure under local anesthesia, and 100% of patients were happy to do that. There were other patients who had also been deemed as fitting the criteria. However, they were booked on other lists where the local was not an option, and we used them as a kind of case control and for our intervention. We did some very thorough carbon footprinting, which I can tell you more about later, and we learned a lot. And here is just a brief summary of our clinical results. Sorry about that. And as you can see, although we had a very small cohort, we had 4 times as many complications in the GA group, although admittedly they're a slightly older population. And we had an average increased length of stay of 4 hours and 10 minutes. So that's quite significant. And what's also really interesting is that apart from the 10 hernias that we managed to arrange under local, there was also a higher number of hernias performed afterwards, kind of organically by the surgical team under local, because hopefully because we raised awareness, and we quadrupled the rates of local anesthesia in our intervention, looking at the same period in 2019 and 2021. So we were extremely happy with the results, and we thought we clearly hit the triple bottom line. We saved 10 kg of CO2 equivalent for each one of our cases. And if we could scale this up and apply it to the 64% of our caseload across the trust, we believe we could save 2 tons of CO2 equivalent per year. Of course, this is also scalable nationally. We do 70,000 inguinal hernia repairs per year in the UK. I think on average we do 10 to 40% of those under local. If we could increase it just by 20%, that's 154 tons of CO2 that could be saved at a national level. And the other beautiful aspect of this intervention is that it is easily transferable to other elective emergency general surgery procedures and other specialties as well. There were also some financial benefits associated with this. And again, if we could scale this up in a trust, we think we could save approximately £16,000 per year. In terms of the social benefits, many of the surgeons thought that they would offer this more as a result of knowing more about the environmental and clinical benefits. And 88% of the surgeons said they felt more aware of the issues of sustainability. As I mentioned, 100% of patients were very happy with the results, the outcomes of their intervention, and happy to participate. And also there are significant social effects by seeing a reduction in the loss of working hours associated with an unplanned overnight hospital stay, both for patients and carers. And of course, if we can increase theatre optimization, we hope that this will also help us clear out the COVID-19 related backlog of operations that we know is pretty massive at the moment. Very quickly to tell you about the gowns. This was a relatively easy transition. The only thing we really had to do was stop people cathartically ripping off the gowns at the end of the surgery and putting them in the clinical waste. But we did that with some posters over the scrub area. And again, we had some fantastic results. In just the first 8 weeks, we saved 1 ton of CO2 by switching only 950 gowns. And between then and now, we have actually switched 3,000 gowns. So we've saved 3 tons of CO2 already. And we have a massive trust. We used 220,000 gowns in 2019. So we estimate that we could save 234 tons of CO2 per year. This is only one trust in the UK. So the results could be really massive at a national level. And these savings are equivalent to driving around the planet 23.6 times. So it's pretty staggering. There's also some financial benefits associated. Obviously, once we can leverage the purchase power of a 200,000 gown contract, we think we'll be able to shave a few more pennies off each gown. But there's also savings to be had from not having to pay for waste, transportation and disposal from the disposable gowns. And finally, staff were extremely happy, and the most important aspect was really they felt it aligned with their staff values and their personal efforts. And of course, a healthy environment means a healthier patient population. So hopefully there'll be some benefits for the NHS from that. And as everyone else has mentioned, we've managed to build some fantastic connections across procurement, management, estates, facilities, and the new sustainability team. And they've all been incredibly helpful. And it's thanks to this connection, we've actually already supported the rollout of the reusable gowns in radiology in another hospital in our trust. They've also had some very good results. We've now got a written approval from all the heads of surgical specialty, ITU, anaesthetics, and A&E to roll out a trial in the departments across 3 sites. We have an implementation plan in place for a business case to the executive by the end of next year to make this a permanent solution. And we've also applied for funds to bridge until then. We've got a grant to test VR headsets for local anaesthesia, and we've also applied for an £85,000 grant to support volatile capture technology. So if people do need to continue with general anaesthesia, they can also do so with a clean conscience. Thank you very much. I wanted to say thank you to all of our fantastic team at Imperial, and we couldn't have done it without them. And thank you to the CSH and the colleges for putting this together and for your time. Thank you.
Thank you very much, Jasmine. Good to see you, Jonathan. I'd like
Hello,
to hand over to hello. I'd like to hand over to Kadar, please, to ask a question.
Wow, amazing work! Congratulations on such an incredible body work, and you've clearly created a movement of sorts, a mobilization, because you're encouraging others to do the same as you've already done. So quite amazing to see the work that you've done. I wondered, this is a rather a small question in some ways, but it's potentially very important from the business case story of the work that you've done. You've not only did you achieve savings because of the change that you made to the practice, and let's just use the local anesthetic for a moment, part of your project, but you also had a very substantial impact, a 4 hours impact on length of stay. And I wondered, in your calculation of the financial case or the financial argument, whether you'd included in that a estimation of the savings you've acquired from reducing the actual time in a bed, whether in the OR itself, whether it's in the general ward afterwards or otherwise. Is part of your calculation of cost savings inclusive of the time that a person spends inside the institution?
Thank you. Very good question. And in fact, you are quite right, because a lot of those financial costs are due to the decreased length of stay. In actual fact, we know that an excess overnight stay is £400. And we also know that every hour spent in hospital has a significant cost because of all the hospital resources. So I think more than half of the cost savings, so the £70 per case, were related to the length of stay. Yeah. So it was a good result.
Fantastic. Thank you very much, Jasmine. Wonderful. So that concludes all our team's presentations. I hope that you're feeling inspired by all those changes that you've heard about. So I wanted to present some data to encourage you all, really, just to present the savings that all the teams made together in only 10 weeks. So Jane, if we could have the next slide to reveal the total savings. So the savings were over 133 tonnes of CO2 equivalent per year. This is a forecast total emission savings from all those green surgery projects. So this is the same as if you were doing a return flight to London to Hong Kong 38 times, if that was allowed, which you can see is an enormous saving in literally just 10 weeks if those projects were continued for a whole year. So this really underlines, I think, what a difference we can make if we all take action, and just, even if a small number of us went away and took action following this conference, what a big impact that could make. So what I would like to pose to you next, as a way of hearing back from what you were discussing in your sessions, was this next challenge. So Jay, next slide, please. We've got a message from Amy Bourne saying that she's learnt to find the key members of the team and get them on board first. Catherine Floyd has mentioned that she would think about connecting to the local public health team as well. We've got lots of things coming through again now. So Edwin, who presented to us, Jay Sadasan, has suggested publishing carbon data to the public. And we've got Paul Jackson here. Thank you, Paul. He's from the quality improvement team in Leeds. He's suggesting setting a carbon saving target for surgical specialties within the trust, which I know you could probably implement. Mahmoud Bata has suggested that his point was that we need a person to lead, someone to make sure that there's protected time to work on these sorts of projects. And then, oh yes, we've got a point here from Konstantinos, reducing the carbon footprint of traveling of staff and patients by offering online consultations and meeting even after the pandemic. That's a really interesting one, isn't it? There's a lot of nuance with that, because it's really important, I think, with that to make sure that the pathways remain lean, because if the digital pathways are not lean, then it doesn't always save carbon, but it is a useful way. Kathy Scott, thank you. Using virtual ward technology for pre-surgery and post-surgery activity. Yes, we've seen that happening during COVID, and this can be rolled out to other areas, I'm sure. Some absolutely fantastic ideas here, which is really exciting. And Alice, thank you. Preventing unsustainable choices before they happen. Prevention, good focus, switching to single-use cystoscopes and even cubicle curtains. These decisions need to be challenged before implementation. Thank you, Alice. Another great message from Shail Shah, monthly audits and meetings to discuss progress and highlight the ongoing progress, thus giving positive reinforcement to the theatre team to keep going on. I think, yeah, using that data to feedback is really key, really helpful possibility. And William Beasley, you think it would be useful to integrate sustainability into the RCS guidelines. I think that's a good way of implementing it. It's good. We're hoping to implement this kind of thing into surgery, into education, into all elements, which I know Tim has said that he would prioritise as well. I'm sorry, Neil mentioned that in his address. Fantastic. So that's really exciting to hear about those ideas and action points coming out, and a final really helpful message from Shamin Janu, who was in the to keep initiatives as simple as possible to start with. So that was a learning point from Brighton, and I think probably the simple initiatives still are quite complex when it comes to implementing them, which I know that you discovered in your project. I'm getting so many good points here. Jade, are we due to move on to the next to the awards now? Still having some. We'll keep hold of the chat. And we've got Tim joining us. Welcome, Tim. It's fantastic to see you. So glad that you could join us. And I know that you were listening in, and even though you weren't able to join us on screen earlier, so it's wonderful to have your opinion. So just for the audience, many of you will know Professor Tim Goodacre. He is one of the vice presidents of the Royal College of Surgeons, and we are honoured, England, and we are honoured to have him here with us, along with Dr. Francis Mortimer, our medical director at the Centre for Sustainable Healthcare. Tim, I'd love to hand it. Oh, sorry, let you say something.
No, I have to apologise for being a techie rookie here, but I had 3 devices open earlier on. I was struggling to the nth degree. It just shows where we've all come from, but we haven't cracked those problems yet. But it's great to be here, and thank you very much for for including the colleges in all this, and it's been. I have listened to absolutely everything that's gone on. I've just not been able to communicate with you before now. So
it's wonderful to have you here. Thank you for taking the time.
I'm hoping that Francis will also chip in, perhaps, with some of the comments that we're about to make.
Of course. So
are you ready? You ready to fire away?
Absolutely. So I think to start with, we were going to just do a rundown of the projects and the strengths that you identified in each one. And so I think the teams are going to join. One member of each of the teams is going to join us now, just so they could be commended, really, because I think all the teams were strong. And then following that, in reverse order, you'll let people know what the prizes are, which is exciting, because I know that we had a pot of cash to dish out to people. We've got 4 members. I think there's just one member to join us. Great.
Congratulations, all of you negotiating this. Oh, well, brilliant. We're all there.
Alice, welcome. Thank you for negotiating those technical issues so wonderfully. So, Tim, thank you very much.
Well, thank you, Olivia. Thank you all for including us in this. It's been absolutely fascinating and an exciting time to help judge these excellent examples of surgical teams taking on this challenge of climate change. it's hard to express actually how much of a positive day I've found this, just hearing and seeing what these initiatives are in the midst of post-pandemic gloom and so forth, when so often so many coffee room discussions amongst surgeons are always cup half empty, and this has been cup half full stuff, which is just brilliant. A rather invidious task actually to try and distinguish between any of the teams today. All of them have been inventive, focused in their approaches in reducing carbon footprints of operations, and all the entries, I think that all the judges felt had very different strengths. We almost felt at one point that we need to have future awards subdivided into sort of one for sort of young innovators, perhaps one for global impact, one for disruptive technology generally, and so on and so forth. You can think of that. But what I can say is that the colleges themselves of surgery across the country, and obviously Edinburgh were due to be introducing this as well, but they weren't here. But we're wholeheartedly behind this initiative, and we do want ideas and communication fed back to us as a conduit to try and coordinate and support, along with the institutes and other sustain all the initiatives that are going on. We are part of this within surgery, and so please liaise with us. We don't want hierarchies anymore, even though I've got a tie on today. We want flat structures, and this is about all of us contributing to the future of our planet. So without further ado, onto the initiatives as they were presented. Plymouth, thank you so much. Impressed by the choice of your project. You consulted the team very early as to what really might matter. A very thorough piece of work. Decreasing the single-use kit within appendicectomy and getting rid of reusable ports and other single-use items. The costings we thought were very carefully worked out, both environmental and otherwise, and so a really lovely project, really succinct and very impressive. Similarly, the Leeds group also on appendicectomies, using big volume. It's great to be able to look at large volume surgical procedures as templates for where things may go in the future. The new device, obviously very impressive, facilitating gasless endoscopic approach, which substituting insufflation, if that can be done not just in this country but globally, is a remarkable reduction in CO2 within the surgical world, applicable across all laparoscopic surgery, presumably, and then including simple measures such as not catheterizing, really going back to what life was like certainly when I was a general surgeon, and streamlining the pack. So several aspects of reduction going on all in one project, and very impressive. So the Sussex group, reducing grouping and saving prior to cholecystectomy. We thought a lot of patient engagement on this in the travel times, costs and so forth. Very good community involvement, and really looking at one particular area with a big review on safety generally. You looked at the pathway, not just the procedure itself, and we were very impressed by that. Applicable to other procedures, it's interesting. We hope that there'll be reduction of grouping, saving, and unnecessary blood tests in many other procedures. But there's the whole matter of where the grouping saving came in because of presumably safety concerns in the past. You've proven that wasn't a problem, but every aspect of rowing back on established practice needs a safety arm attached to it. The Welsh group, looking at a field very close to my heart, hand surgical procedures, showing this dramatic reduction in equipment. Most impressive again, probably applicable across a much wider operative range, and I think something which we can learn from. Certainly in this country, globally, I suspect there's a lot of hand surgery undertaken with very minimal kit out of expediency, but we were interested in that. As yet, it's not been taken up by others in the team, but you to certainly introduce new design rules for greening surgery, and we were very impressed by that. Likewise, onto the Imperial team, the whole transformation of hernia repair towards local anaesthetic, a very comprehensive review of that, and looking at the health economics of it as well as the reusable gown transformation. Again, changing two of the design rules, which are about how the surgical procedures are implemented. So I can't really do anything more. I don't want to sort of prolong the summing up. I don't know if Frances has anything she wants to add to that, but I think altogether these ideas we need to really spread all these ideas and continually look to future ideas for improvement. And those suggestions that just came up on the screen, I thought were beforehand, Olivia, you were running through, really exciting. And I think if we need more and more brainstorming on how we transform surgery and get the message out to some of the dinosaurs of my generation, but many of let's continue this transformation that's going on. So as part of this, we have these very small cash prizes to award. They're almost embarrassingly small, but we're most grateful for the sponsorship that we have had. And let's hope that we can grow that in future so that it really makes a difference. But what matters most is that you've contributed, and we've seen what's possible, and we can spread these ideas. So in a sense, everybody today should consider themselves a winner. I'm going to announce, though, in reverse order, 2 runners-up, because we could not split the running at runners-up. And I'm going to ask each of you to perhaps to comment, but there will be 2 awards of £400 each to the Welsh group and to the Imperial group. So both of you have an award. And perhaps we can move to. Can I ask our team from Wales to come in and just comment on that at all? Say a few words before accepting the prize.
Yeah. First of all, thank you hugely for the opportunity to Olivia and Frances and her wonderful team at the centre. Gave us a huge amount of support. This has been a journey for all of us. I need to thank, obviously, my wingman, Mr. Kodamuri, who did a lot of the lion's share of the actual data gathering. He's a real doer, and I take my hat off to him. And Sian Roberts, who's my theatre practitioner, my scrub nurse, who helped me in the case. Yona Williamson, our sterile services manager, and Jack, our junior doctor, who helped us with this. I'll mention them all on Twitter properly, with a big thumbs up. And this is the start of the journey for us. And we're very, very pleased. And like I say, we feel we're all winners here. And hats off to the other teams. They blew me away, all of them. They were brilliant.
Thank you.
Very honoured to be here. Thank you.
Thank you, Prash. That's great. And can we move over to our Imperial team?
Yeah, hello. Thank you so much. That's a huge honour, and yeah, we're exceptionally happy. I want to say thank you to the amazing people on the team who have just been absolutely instrumental, and we couldn't have done it without everyone's collaborative efforts and the support of all of the theatre staff, as well as facilities and Synergy and ANZE. And it's been great. It's been an amazing journey, and seeing how many people are really enthusiastic to jump on board. And I thank you very much for having us, for giving us this opportunity, for making it happen, because without this formal backing, none of this would have happened. So it's a great result. And I think all of the teams, I agree with Prash's amazing work. So it's been great to be a part of it, and I look forward to seeing more. Thank you.
Thank you, Jasmine. That's great. Well, thank you. Congratulations to you, the 2 runners-up. It is not fun never to say to somebody they haven't gotten an award, because truly all these were exceptional projects. And so my commiserations in a sense to Derriford and to Sussex, but we do have to move to the clear winner from the team's perspective, from the judges' perspective, were our group in Leeds, who we felt had covered all bases and were the overall winners. So I'd like to invite you, Leeds. You have the grand total of £1,000 as your prize, but it's you are the winner of the Global Surgical Challenge this year, the Green Surgical Challenge, and I wonder if you'd like to make a few comments.
That's utterly amazing. Thank you very much. I have to say, kind of having listened to the other presentations, I didn't think we really stood a chance, actually. So I'm slightly shocked and amazed, but thank you very much. I can't not thank, I know everyone's kind of thanking their teams, but I really need to mention a few names, I have to say. So Aaron and myself have obviously led the team from our perspective, but we really could not have done this without our kind of other members of the team. Pete Kilmer, who's a medical engineer who has kind of worked tirelessly to design the race device, has been instrumental in sort of developing a lot of this work. We have a medical student, Tim Ho, who is a third-year medical student who is going to go on to do great things in the future. I have absolutely no doubt. He has single-handedly done all of our kind of green calculations and made brilliant. It's just been utterly brilliant. So I need to thank him. And Katie, who is one of the team's SHOs, who has really driven the project from process mapping and various other things. So without them, absolutely. And sorry, I should mention Tom Pike as well, who is responsible for that video. I really can't. We couldn't have done it without them. It's really exciting, I have to say. I think this has been a real game changer. Aaron and I, when we first met Olivia, were very much, we got asked what our green credentials were. And I think we kind of felt a bit stuck in answering that question initially, but I feel we've been on a massive journey, and we're very much converts, and we'll drive these projects forward in the future. And I hope we can inspire other people to do it as well.
Thank you, Adam. I think that's been one of the most exciting elements of this whole challenge. Really, it's been seeing people. And many people going from a place where I think when I first spoke to you, you didn't really have a concept of green surgery at all. Going to a place where you've really transformed your program is really exciting. So well done. And I hope you go on to do many more projects, and that the prize helps you to do that as well. Thank you.
Absolutely. It'll be well spent and go to well-deserved causes.
Fantastic. Thanks.
Thank you. Thank you all.
Wonderful. Well, thank you very much, everyone. And I think I just wanted to pick up on one of Jasmine's comments, actually, just saying that she felt that they couldn't have done this without some extra support. And we know that not everyone had the opportunity to go into the Green Surgery Challenge, but we just wanted to reassure you that there are plenty of other sources of support, partly from us at the Centre for Sustainable Healthcare, also from the colleges, which I'd just like to raise to you now, so that to help you on your sustainability journeys in your surgical practice. So I'm going to ask Jane just to put a couple of slides up, and then we'll just finish with some thank yous. Francis has just commented there. Francis, would you like to just speak out your comment whilst these slides come up? That'd be lovely to hear from you.
Yeah, I think the thing that struck me in reading the reports of the projects beforehand and in hearing about them today was the amazing power of the quality improvement approach applied to the challenge of sustainability in surgery and in healthcare, and just the rigor and the thought that had gone into all the projects and the measurement. And I think that's just going to be foundational to how well they can be spread, because all of the projects had elements that embody what a sustainable surgical system could look like in the future, whether that's less kit or less general anaesthetic or all the other elements. And I think, but in order to move through and get those ideas spread and embedded, you really do need the compelling data and the in some cases the safety concerns addressed and all that work that goes into it, and the local engagement. So really excited to see all that work coming together now.
Thank you, Francis. That's really useful comment. Thank you.
Olivia, could I just encourage anybody also to consider the research fellowship schemes, which we offer and other colleges do as well, just to sustainability and greening surgery is now entirely acceptable and in fact an encouraged format to look at for future research projects. So seed core funding, there's those initiatives as well. So do look at those.
Oh, fantastic. Well, what we'll do is get the links for those, Tim, and we've got a resources section at the bottom of our page, and make sure that people have access to those after the event. So thank you. That's really helpful. I'll just run through some other resources as well for your future green surgery projects. I'm sure many of you will be starting. So, of course, one of your resources will be the existing teams. All of the teams are leaders in sustainable surgery now and have got wonderful expertise. Contacting them is a great way of finding out more from their experience. Next slide, please. Also, there are sustainability and surgery groups, both at the Royal College of Surgeons England and the Royal College of Surgeons Edinburgh, and we'll certainly have the links available on the webpage after the event, and I think Vivian's just putting them in the chat for us here as well. Next slide, please. There's also a network on our network site. There is actually a sustainable operating theatres network. Next slide, please. Which has a similar icon to the green surgery, and on there you can pose questions, get answers, share your projects, and get input from others there. So it's a great resource for problem solving and showcasing work. And as you go through your projects, if you want to using a sustainable quality improvement approach is a really powerful method of change, and there is a toolkit that is freely available at this website to help you on that journey. And this is methodology that all the teams have used. Next slide, please. There are courses, so if you wanted a bit more guidance on sustainable quality improvement rather than just the toolkit, there is a course. The next one's on the 24th of November, and there's one in January and March as well, and there's a carbon footprinting for health course as well. Next slide, please. And then in terms of research, obviously Tim's mentioned that there are the research fellowships, but if you're looking for evidence, the previous slide, please, there is the Brighton and Sussex Medical School Sustainable Healthcare Group, which is led by one of the chairs here, Professor Mahmoud Bata. He's also on the Sustainability in Surgery group here at the Royal College of Surgeons England, so that's a really helpful resource. Next slide, please. We would love your feedback because this is the first green surgery conference ever, so it'd be lovely to see your feedback if you fill in those very short surveys. And then finally, last slide, please, Jane. Just really a vote of thanks, and so many people have gone into running the challenge and this conference. This is sort of the last phase of the Green Surgery Challenge marked by this conference. So thank you to all those people. It's been a tremendous effort from many people, and I think been very successful in building a movement for sustainable surgery to make surgery fit for the future. Thank you, everybody.